Have you ever stared at an ECG and felt like drowning because it was looking a bit confusing? This is how you're going to get through it. It's very simple, and we can break it down into fast life-saving steps that will be very, very useful for you. So let's just get to the point. The first thing you need to do, and you can do this, I said 2 minutes in my presentation, but you can do this in barely 30 seconds. And it's by saying Raik. So once you get your ECG, let's say the nurse has done the ECG, or as a paramedic, you were the first responder, you did an ECG, or you're the student and they just want to check the ECG by you. You need to quickly check that it's not an emergency. So you don't need to know every ECG diagnosis in the books. You're never going to know every single ECG clue. What you should focus on is just say, is this patient in need of immediate intervention, or is this something that looks normal, or is it something that we can still buy some time with? And that's when RAIC comes to mind. So double R, first is the rate. In this day and age, the rate is always done for you by the ECG machine. So on your ECG strip, many times in the left top corner, you will find an automated ECG rate done for you. Otherwise, you'd have to manually count. And you manually count how many QRS intervals you have in 30 big squares and multiply by 10. Now, this can be also, that can take you more time, but like I said, rate is always done for you. If you have to do it manually, then I'll suggest you do that with a ruler, because with a ruler, you don't need to count anything. You just put it in between two QRS intervals and it tells you the rate. Now, let's go back to RAIC. So rate, if it's done for you, that takes you 0.1 seconds. Secondly is the rhythm. The rhythm is there a P wave followed by a QRS wave? Is there, for every QRS you have, do you have a P wave in front of it? That should take you another 0.2 seconds. You should be able to, and for me, I like to go to lead 2. I look at my lead 2 strip and I just see, for every QRS interval I have, and I've drawn the QRS here for you, do I have a P wave before it? And if that's the case, this is likely a normal sinus rhythm. But we move. The next one is axis, and what you're doing is a quick scan of leads 1 and 2 for axis deviation. Now, if I always say right to case, if the QRS in lead 1 and 2 are positioned in such a way that they are facing one another as if they want to kiss, that's right axis deviation. If they are moving apart from one another, that's left to leave, and that's left axis deviation. I have another video where I break down very slowly what you need to know about left axis and right axis deviation. So the next thing you want to do is your interval. Now, interval, I said this should take you at most 5 seconds. And what are you looking for? The intervals of 3 things. The intervals between the P and the R, the interval, your QRS interval, and your QT interval. Now, going back to my last slide, I did draw the wave for you. Your PR interval should not be more than 0.20 seconds. So normal is 3 small squares to 5 small squares. That's 0.12 to 0.20 milliseconds. And when it becomes more than this, you may be thinking of a heart block, right? For QRS, it shouldn't be more than 0.12. That's 3 small boxes. When it's more than 3 small boxes, then that is a wide complex QRS. And you want to check if there is tachycardia, that it becomes a wide complex tachycardia. We know that tachycardia is heart rate above 100. So you'll be having a wide complex tachycardia, which will be a ventricular tachycardia. More on that later. But just check. PR, is it between 3 and 5 small squares? Is a QRS not more than 3 small squares? And what is the QT interval? Again, the QT interval has most likely been done for you at the top of the ECG sheet. It comes with most ECG machines now, and all you just have to do is to check the value. Otherwise, you may start measuring this. If none of these have been done for you, and you have an ECG ruler, which I highly recommend, you can find one on our one that is very well designed and high quality standards. You can find that one on our page. So if you have a ruler, the better for you, because you just put the ruler against the P, you put the ruler against the QRS or the QT, and then you discover if it is short or prolonged. Now, the next thing to do is, I always say I for intervals, but as part of my high, I always check for any ischemia or any other problems. So There are only three killers, I've said it at the beginning of this presentation that you would have so many things to check on your ECG. In fact, you should take some time to look at the ECGs of a sick patient. But there are three things that you need to quickly rule out in the first couple of minutes. That is the ventricular tachycardia, which I just described. If the QRS is wide complex and the heart rate is high, above 100, you're dealing with a ventricular tachycardia. If the P, and it's not like you're checking for these things are fresh. If you've had these three things in mind, the moment you started with your rate, your reading, your axis, your intervals, you're already putting these together. So for example, when you were checking for a sinus reading and you saw that a P wave was following a QRS wave, and you're checking for every QRS is a P wave following in complete heart block, the P wave is dissociated completely from the QRS. So you find that it's not every P wave that is being followed by a QRS wave. Not really, not necessarily, there's no pattern to it. And, I have a whole video on that. So if you find some P waves not followed by a QRS wave, or the distance between P waves and QRS keep varying, keep in mind there's a heart block likely going on here. Now, the other thing you need to know is your ST elevation. Is there ST elevation or ST depression? Because in any sick patient, especially when they have chest pain, but sometimes they don't even have chest pain, they complain with abdominal pain, they complain with shortness of breath, or they're just unwell, you need to make sure that they don't have a MI. Because if they have a myocardial infarction, they need to be transported within the first few hours to a cath lab for coronary interventions. So it's very imperative that as the first doctor or clinician or paramedic seeing that you are able to read this MI, read that there's ST elevation on this strip and call for help, right? So I put this together. Oh, I did miss the previous slide, but you may be able to rewind that back. Oops. So I did miss those slides, but those were pictures of showing you what features of ischemia are. Now, the features of ischemia, T-wave inversion, the T-wave is in an opposite direction. I'm doing the recording right now, so I may not be able to rewind back, but you would be able to go back and look at the pictures. T-wave inversion, pathologic Q waves, ST elevation, ST depression. When there's ST elevation, then you need to look at your patient. Now, the last bit, I did say RAIC. We did the rate, the reading, the axis, the intervals, and while you're checking the intervals, you can use that again to check if there are any features of ischemia, injury, or death. Death is actually the infarction, but is there any injury? I for interval, so your high you can also use it to check your ischemia, your infarction. And then the last one, which is C, is the most important. Because in any case, you're just using the ECG for clues. You are treating the patient. So always treat your patient, right? So what is the context? So let's assume that, for instance, I see an ECG and the ECG is just chaotic waves looking very abnormal. And I say, oh, where is this patient? Let's say the heart rate is about 300 and I'm just seeing chaotic waves. And they show me the patient, and the patient is just right across the emergency department, smoking, laughing, happy. I know that ECG is most likely wrong. I will definitely ask more questions. I'll say, oh, can I see the patient? Or are they doing fine? So, because why? Ventricular fibrillation, for instance, is not compatible with someone who is alive. Ventricular fibrillation, you're either dead or about to die. So I know that ECG is probably false, and there's no, there might not actually be any need for me to start running around at that time. But if, on the other hand, I'm seeing tachycardia, I'm seeing wide QRS complexes, and I ask, how is this patient? Because that's the context. Oh, or what is this patient coming for? And they tell me, oh, patient is hypotensive, blood pressure is 86/48, or they can't breathe, or they are complaining of serious chest pain. I know I've got to move in fast in the first few minutes because this patient may need immediate intervention, right? They may need some shock. They may need so many things may be needed, and because from ventricular tachycardia, if they're hypovolemic, or if they are dizzy, they're having features of chest pain, or if they're having syncope, they will very rapidly progress into either ventricular fibrillation or other types of worse rhythms. So you want to make sure, for example, if I'm saying ventricular tachycardia, for instance, I want to know, you know is there a pulse in this patient? Because for pulseless ventricular tachycardia, you should immediately switch to your algorithm, your resuscitation algorithm, shouldn't you? For pulseless ventricular tachycardia and ventricular fibrillation, you should be getting defibrillation immediately. So these are the things to consider, and that is why you need to just put those things in context. Now, so your context is king. Where is this patient, or how is this patient, or how or for what did they come in? That's very important. Now, I just put up an ECG so that we can do this together. The first thing is, like I said, let's assume I was giving this ECG in anywhere. Let's assume the emergency department. So my first quick thing is, what is the rate? Remember my RAIC, first R, the rate. So what is this rate? This rate, it's not been done for me here, like I know it will be done for you in real life. I'm not able to use my ECG ruler now because I'm presenting this and you might not see my ruler. But if you count 30 big squares, you find about 13 QRS intervals, and I just use the R. The R is the pointing hook on top, and you multiply by 10, and that is 130. So this person is tachycardic. Rates done. The rhythm, is there a P wave followed by a QRS? And I'm using my LED2 strip like I told you. And in this case, there's a P and then there's a QRS wave. So this is looking more like a sinus rhythm, right? I look at my axis, look at my LED 1 and 2. The QRS intervals are both pointing upwards. They're not pointing towards another, and they're not pointing like they're leaving one another. So this is a normal axis, right? The intervals, the PR interval here, the PR interval is looking at about, I'm trying to zoom in and count how many small squares. You'll be able to do it more accurately, but it's looking about 5 small squares. I'm okay with that. If it's 5 small squares, the PR interval is fine. The QRS interval is also looking about 3 small squares. That looks fine. The QT interval also, that is from a Q wave up to T. Now, there's hardly any T wave here. Would you agree? Something is wrong. Something is definitely wrong, because I cannot really, after seeing the peak QRS, do you see how the QRS wave dips? And you can ideally find a T wave before it turns to a P wave. I know there is something wrong, and my QT interval here is likely messed up because I'm not able to check that T wave. Now, the next thing, so I already have 2 queries. 1, there is tachycardia. 2, it's looking like my T wave is a bit inverted, right? Would you agree that it is barely visible and looking inverted? Yes. So the next thing, under my eye, which is still my intervals, is ischemia. Now, are there features of ischemia here? And for ischemia, what did I say we check? We check ST elevation, ST depression, T wave inversion, and we check pathologic Q waves. There's definitely some sort of T wave inversion in my LED 2. There is ST depression in my V4, right? There's ST depression in my V4. There's ST depression in my LED 2. Yes. So there's quite some ST depression, would you agree? And so I need to know, because I've just done my eye interval ischemia, I need to know what the context is. What is going on? Where is this patient? What did they come in with? There's ST depression in V6 as well, in V5, in V4. And as you can see, some other levels of ST depressions in LED 2. Exactly. And then T wave inversions. So it's showing features of ischemia, it's showing features of tachycardia. I want to know my context quickly. Where is this patient, or what did they come in for? Oh, this patient has chest pain. And that is where the drama begins to unfold. Because with my ECG, I have picked up important clues and I've checked the context. And I know there's every reason for me to be concerned. I want to know the vitals. I want to know what the troponins are. Have they had bloods done? Are the bloods out? What immediate treatment have they given them? Have they been given the Mona, the morphine? Did they need oxygen? Are they saturating well? Are we giving them, a nitrate? Are we giving them aspirin, 300 milligram start? Have they improved? What is you want to do your quick ABCD analysis: airway, breathing, circulation. You want to see their GCS, their glucose levels. Once you're done with your emergency assessment, then you start looking at their history, their background. Did they come in with chest pain? Are they diabetic? Are they known to, did they have a recent heart attack? Do they have risk factors, hypertension? You want to start putting the story together, but this teaching is just for the ECG, for you to be able to assess it in under 2 minutes. And so, I sometimes I press the button and it goes too fast while recording this. But let me know if this was useful for you. If you have any questions, please feel free to drop a comment on our Instagram page or DM us. I have we do have several resources in PDF version. Let us know which format would be best for you in PDF versions, and we are happy to assist. Of course, we have so many other programs, but I'm not here to upsell you on anything. I just want to make sure that you have the basic tools to read any ECG on earth in this world by following the 6-step RRAIC. No, it's not 6 steps actually. It's rate, rhythm, axis, interval, stroke, ischemia, stroke, infarction, and context. So that's basically about 5 steps to be fair. And with that framework, there is no ECG in which you will miss a red flag. Thank you.